Academic institutions face a constant pressure to balance their limited faculty resources with the requirements of patient safety. Miller's pyramid of clinical competence highlights the separation between written assessments of knows how and the practical shows how level of live clinical simulation. To bridge this distance, faculties have traditionally relied on modified essay questions, or MCQs, to evaluate diagnostic reasoning before students reach the clinic. However, grading MCQs is resource-intensive. To save thousands of grading hours, there is an administrative trend to replace these scenarios with short-answer questions, or SAQs. Proponents of this shift point out that both formats are constructed response exams. On a curriculum blueprint, they appear to be functional equivalents. Substituting SAQs for MCQs changes what the exam is actually measuring, potentially masking gaps in a student's clinical competence. Standard multiple-choice questions are often susceptible to cueing. The presence of the correct answer on the page triggers passive recognition rather than active recall. Both SAQs and MCQs successfully eliminate this guessing factor by requiring the student to generate their own text. Despite this shared trait, the two formats target different cognitive domains. They are not psychometrically interchangeable. Understanding why requires an analysis of the textural differences between how these two assessments are constructed. Treating a static snapshot of knowledge as equivalent to dynamic reasoning is a significant error in assessment design. Structurally, the short answer question is designed for broad curriculum sampling, testing a high volume of facts in a single sitting. As the research indicates, SAQs isolate specific knowledge points. The format might require a single word, a fill-in-the-blank, or the completion of a specific sentence. The SAQ is a static node requiring one isolated output. The MEQ uses progressive disclosure following a patient's chronological timeline. Stage 1 requires a preliminary decision from limited data. Stage 2 reveals new complications, forcing students to adapt their initial plan. This sequence is strictly secured. Students cannot use backward cueing or retrospective hindsight to go back and correct their earlier reasoning. While an SAQ tests if a student possesses a fact, the MEQ tests the process of how they manage evolving data and ambiguity over time. These structural differences map directly to established educational theory, specifically Bloom's taxonomy. SAQs target Bloom's levels 1 and 2, remembering and understanding. They test the student's ability to apply memorized rules to a static prompt. MEQs are explicitly built to assess Bloom's level 3, problem-solving, synthesis, and evaluation. This level of assessment requires a clinician's index of suspicion, the ability to reformulate hypotheses as new clinical variables appear. The MEQ timeline forces the student to demonstrate this index of suspicion through documented, sequential decision-making. Because an SAQ cannot measure a student's ability to pivot during a case, it is not a direct substitute for Level 3 testing. There is a common misconception that dynamic reasoning tools are only useful during late-stage clinical clerkships. In practice, utilizing MEQs in basic medical sciences and preclinical operative dentistry is a valid and necessary component of the curriculum. A standard preclinical SAQ might simply ask a student to state the required convergence angle for a full crown preparation. A preclinical MEQ would instead present a case, ask for a preparation design, and then introduce a sudden complication, forcing an adjustment based on histological principles. This influences the washback effect, where the exam format dictates how students study. Early MEQs drive positive washback, building integrated concept maps instead of rote memorization. Introducing reasoning early prevents students from adopting shallow learning strategies that may fail them once they enter the clinic. We must address the primary logistical argument against MEQs, the considerable resources required to grade them, and the risk of marker subjectivity. This subjectivity is an operational hurdle that faculties can manage through specific grading protocols. Reliability for summative exams requires meeting strict statistical thresholds, specifically a Cronbach's alpha in excess of 0.7 to 0.8. The Discrepancy Agreement Grading System, or DAG, provides a structural solution to rater variance. The calibration process involves using structured model answers and rigid analytical rubrics, while training markers against a gold standard examiner. With these protocols, the MEQ can achieve the same level of statistical defensibility as computer-marked tests. The generation effect describes the cognitive effort required to produce an original answer. This process can uncover deep learning gaps that recognition-based tests often hide. Academic institutions should not allow administrative convenience or grading fatigue to dictate their assessment strategy. SAQs and MEQs are complementary. One measures the breadth of knowledge, while the other evaluates the depth of reasoning. To develop practitioners capable of navigating real-world practice, the MEQ must remain a foundational pillar of the assessment blueprint. Ultimately, the MEQ serves as a link connecting classroom theory to the clinical decisions that impact patient safety.